When we can help more efficiently allocate capital to people's healthcare, we can cover more people, we can get better outcomes, we can reach a bigger set of geographies. All of these things have to come with hopefully spending fewer dollars, right? Yeah. We don't have to pick between better healthcare and sort of more spend. There's so much inefficiency in the industry. We can lower spend, hopefully, and improve outcomes. That's what Clover's all about. I'm Andrew Toy from Clover Health, and this is the future of insurance.
Business is anything but usual these days, but with VPay's claim payment solution, you can replace checks, reduce costs, boost e-payment adoption, and start realizing savings in just 45 days. Easy, safe, and smart. VPay, now a part of Optum Financial.
Andrew, it's great to sit down with you again. I think it's been maybe a year or something like that. It's been around a year since we talked last time.
That sounds about right. Nice to be here. Nice to see you again, Bryan.
You were very generous with your time when I was writing the case on Clover for the Future of Insurance Volume 2. And it's great to bring you back on, or bring you onto the show for the first time, but sit down with you again. And I'm going to make you rehash a lot of the same stuff, if you don't mind, for people who don't know about Clover. But before we do that, quick one on you, because you're not an insurance person. So tell us a little bit about your background.
That's right. Thanks, Bryan. So wonderful to be here. My name's Andrew Toy, and I am the president of Clover Health. And we are a health insurance company focusing on Medicare. And Medicare is the US program for seniors over 65 and the disabled. And so that is where I am. I spend my day-to-day running a health insurance company providing care for seniors and the disabled. My background, though, like you said, is actually in software. I am a software engineer myself by training. I, wrote code all the way back from being maybe 5 years old. The first program I ever wrote, this is how long it was actually saved onto cassette tape, not even onto floppy disks.
Wow.
It's that long ago that I wrote programs. So trained software engineer. I actually grew up outside the US in Hong Kong, came to the US for college. I've been very focused on how we apply technology to transform industries and make things more efficient, improve how we actually live our daily lives. I will spend a lot of time in the mobile industry. I had a startup before, which I sold to Google and built the tech for a lot of Android security, built into lots of different Android phones. So it was a big part of the mobile revolution, and then decided to come into both health insurance, healthcare and health insurance, because the way we deliver healthcare in this country is via health insurance, right? And so decided we really need to change how we all get healthcare, how we get better outcomes at lower costs in the country. And to do that, thought about bringing technology and technological approaches to an health insurer, an insurance company, because when we can help more efficiently allocate capital to people's healthcare, we can cover more people, we can get better outcomes, we can reach a bigger set of geographies. All of these things have to come with hopefully spending fewer dollars, right? Yeah. We don't have to pick between better healthcare and sort of more spend. There's so much inefficiency in the industry. We can lower spend, hopefully, and improve outcomes. And that's what I'm all about. That's what Clover's all about.
No, that's great. And I think, this is the false economy of the US healthcare system, is we spend more than anybody and we don't have the best outcomes. And we're not living the longest. We aren't the healthiest. The list goes on. Absolutely. So value for money is not there. It is totally you can't just throw money at this problem. In fact, you seem to make the problem worse after a certain point, right?
Absolutely. Absolutely. I think that it's interesting because we are one of the few countries which almost exclusively provides healthcare via the insurance model, right? There are other countries, almost all countries offer some form of health insurance, to be clear, right? But most are backstopped by a generalized socialized system, which sort of raises the floor on the level of care you can receive. And then you buy insurance beyond that and pay premiums, et cetera, if you want above and beyond that. that. The US almost exclusively uses some form of insurance, whether it's government funded or private funded. And so to your point, because of that, we have this tripartite marketplace. It's not just a consumer and a doctor, like a patient and a doctor. It's a patient and a doctor and a plan, always figuring out what's going to happen, which makes it very hard to get efficiencies.
Yeah. Well, so there's a lot to the story of the founding of Clover and why it came to be, and it was born out of a healthcare system. But you mentioned this thing about, if you can lower the cost and improve the outcomes, you get it to more people and society does better. Like that genuinely is what's behind the idea here. Hearing that founding principle, it was people who are on a mission to try to help others, which gets back to the point of healthcare and gets back to the point of insurance, right? It's about making people's lives better when they've hit something, something difficult. So it stood out to me for that reason. I don't want to rehash the whole story because there's a lot to it, and it's not me trying to sell the book, but people can get that in the book. But there is something very materially different, and it's the thing that brought you into the company around Clover Assistant. Can you tell us a little bit more about this? What is it, and what's the intention of it?
Absolutely. So Clover Assistant is our basically software platform that we build at Clover. It's built on our data platform and ingests a lot of different data points from labs to pharmacy information to electronic medical record information across multiple sites of care in the US, and then sort of digests all of that, and we provide it to primary care physicians, and it enables them to basically provide data-driven primary care. And so that's in our entire philosophy is, imagine if your primary care physician, and we believe everyone, certainly everyone on Medicare, needs a primary care physician that they trust and that they choose, right? And then that physician can then be empowered with data and information to let them provide the best personalized care. When we can do that, then you get those better outcomes at lower cost. So Clover Assistant is about giving out our software, giving out access to our data. And we actually don't charge for Clover Assistant because we are an insurance company, right? We win, and society wins, and the government wins when we are getting those lower costs and better outcomes. So we actually share that back with the physicians and say, insurance, it's clever here to spend money, but in the right way. Yeah. Allocating dollars to data-driven primary care is very efficient versus waiting for an adverse outcome to occur and then paying for an emergency department visit. So because of that, we are able to give out our software, give it to lots of different physicians, let our members and our patients pick their primary care physician, know that we're going to have that data-driven care, and those PCPs actually are able to bill a higher rate for their primary care at a higher fixed rate, and we avert like much more expensive or adverse outcomes for our membership.
There's a ton to what you just said, and I think for anyone who's had an HMO or most other insurance plans, that if you get a fixed network, it's so your choice of physician is often limited. You change plans, or your employer changes plans, or like the carrier just changes their network, and suddenly your doctor you've seen for 20 years, you can't see them anymore, or your kid can't see their phizician anymore. And I know we're talking about Medicare, so we're not necessarily talking about kids, but you kept saying you can see your doctor. You do provide choice. There are a lot of the tools that insurance has been using, health insurance has been using to try to control costs, which have not worked, by the way. Look at costs. You don't use those tools. You give people the flexibility and the freedom, which again stood out to me is that's one of the most frustrating things in health insurance is the constraints that aren't helping us do better. It's like you guys keep saying, no, we're not going to constrain it that way. It's like, wait, but we've always been told that's how you keep the costs under control. And you're just looking to informing the care and assisting the care is probably a better word, rather than, well, let's handcuff everyone who's involved, the patient, the physician, everybody. And you pay them more if they use your tool, which again is like, for anyone who's a doctor who's listening, I know they're like, we have too much to do. And you made this point to me when I was talking about the book is like, we recognize it takes them more time if they're going to use this, and we can't just ask them to do that for free. So we pay them for it, which sounds really reasonable, right?
Absolutely. I mean, you raised a lot of great points, and we did discuss it when we were preparing for the book. But doctors are seen as an altruistic sort of like calling, right? And pretty much they are, right? You get into being a doctor because you want to help people, but that doesn't mean we as a society or we as health insurers should take advantage of that. We shouldn't be like, you want to help people, so do it for free. That doesn't make sense. And as any physician will probably tell you these days, time is so important to them, like you said, right? Like they're filling their time with like trying to see patients, see as many folks as possible, trying to do their documentation, trying to figure out value-based care, which is really difficult. So the easier we can make their lives. And I think, even with Clover Assistant, we haven't solved this problem. I think it's a good step in the right direction, but it enables us to say, to your point, see the doctor you like. We trust doctors want to do the right thing, but they might be missing information. You might have seen an emergency room doctor in a different health system, and they don't know you did that. You might have seen a specialist, and they don't realize that you went to see that specialist. You might go in with a migraine, and you don't realize that you have an infection on your diabetic foot ulcer that also needs looking at, and you didn't mention it. So how was the doctor meant to know that when you walked in, right? There's so many places our health system can slightly go wrong, and then get worse and worse when your PCP is just not as informed. So our goal is make that better and better. And then to your point, there just aren't enough doctors as it is. We know this, right? As patients, we're like, well, the issue is getting an appointment, figuring out how to like fit into that schedule. Like, is narrowing the number of doctors you can see going to help with that problem? Like, obviously not. We need to make it easier to see a doctor. And so we want to say, pick the doctor because trust is so important. And how do we increase the supply of doctors giving great care? By having open networks. And that's a pathway to all of us getting better healthcare, better health equity outcomes, because different communities want to see different doctors. All of this good stuff comes from having a bigger, broader network approach combined with data-driven health insurance.
Well, and so tell me a little bit about what is it that the assistant's doing when you say data-driven care? What's the data? What's it? And you mentioned some things just now, but how does it actually help the physician?
Yeah, absolutely. So I think the number one thing that we're trying to do is gather information across a very fragmented healthcare system, right? And so the example I always give, I think I mentioned it to you for the book as well, but it's very intuition setting, is that when a doctor, or even our doctor, Medicare or not, prescribes you a medication, you'll see them go into their EMR and click and say prescribe medication. But the vast majority of time, unless you pick up that medication literally in the hospital's pharmacy, which most of us don't, right? We'll go to a Walgreens or a CVS. That doctor has no idea whether you ever picked up the medication, right? Just absolutely no idea. Like the pharmacy knows. There's just no system to like talk between those two pieces of software, right? So we as a payer, as a health insurance company, the one thing that's really helpful is that all of this gets charged to the health insurance company. So we can use the fact that we're allocating the dollars as we should to say, oh, Bryan did pick up their med because I see that, there was a claim, there was a charge for that medication. And, we get told what medication it is and when you picked it up and all this good stuff. And we can even say, well, that was a 30-day supply that Bryan picked up in January 1st. And you know what? It's April now and we never saw that get picked up ever again. Right. And so a very simple thing we can do for a doctor is say, when you go back and they see Bryan again, they're like, I prescribed it. Bryan picked it up once, 30 days worth. It's been 90 days and there's only one pickup. Bryan's not taking his meds on a regular basis. Right. That's very hard to do, actually. As a physician, you might even ask Bryan, like, hey, are you taking your meds? And I'll just say that almost certainly you will say yes. Of course I am, doctor. Of course I am, right? Most of the time, people don't say, no, I'm not, and I don't want to, right? But for us in Clover Assistant, we can say, hey, we're not trying to do it. What we're telling you is Bryan only picked up one 30-day supply. It might be something where it might be a socioeconomic issue where the meds are unaffordable. It might be a convenience issue. Maybe you're working 2 jobs and you can't pick up. You don't have time to pick up your medication. You might have forgotten. You might have gotten embarrassing side effects and you don't want to tell anybody that
you're not passing judgment.
That's right. We're not passing judgment. We're just letting the doctor know. And then the doctor is trained to have that conversation, if that makes sense. They're like, let me sort of have that convo, right? So it's a very simple thing where that's a basic example, but there's so many of those. Another thing we do is early testing and early detection, where an example I give, and I think I mentioned before, is when a patient comes in and they are complaining of migraine, all that doctor is going to work on is migraine, right? It's so that they're like, just fix the migraine, fix the migraine, right? That's all you're going to want to talk about. But just because you have a migraine doesn't mean that you're not due for colonoscopy, right? And so what we'll say is, hey, yeah, of course, work up the migraine. And we've seen you're working that up every month. But this patient has never had a colonoscopy. They're certainly of the age to need one. They are at high risk. You probably need to get them in for a colonoscopy too, right? And so that example, again, we're not forcing the doctor to do anything. A lot of electronic health record systems will say, you must order the colonoscopy. We're saying, you use your clinical judgment, but we really think it's a good idea, right? And it's a partnership with the doctor.
And I think what's interesting is you gave me other examples, like, are they staying on top of their diabetes, even though they're here for something else? We haven't talked about this, and should we? Here's a suggestion, not a do this or don't get paid, or you can't close the file and we're not going to let you move on to your next patient or whatever. There's no penalization. It's just present information and let their expertise weigh in. A lot of the examples that you used cost you more money.
Yes.
And I could say, well, if you're not a public company, you don't have to care about that because you can make the right long-term decision, but you are a public company. And so to be able to make a short-term higher cost decision that is a long-term benefit, that's the way it should be working in healthcare, but it often isn't. And, what was fascinating to me is we talked in the heat of lockdowns. And you were, so like your medical cost ratio, which for those of us in PNC is like a loss ratio, right? It's how much of your premium is going to the medical expenses, was lower than what you expected it to be, which I think in PNC would be like, oh, that's great. Your loss ratio is low. And you were like, well, actually we're concerned because it means people may be staying at home instead of getting that regular care. And so yes, our costs are down, but that like your longer term view, which health is a long-term thing, allowed you to see that that's fine for today, but that may not be the right answer for us long-term for the patient or for our finances. Like that, recognizing that flip. And I think in insurance, we miss that. We won't pay to tent your house when you have termites, but we'll pay when your house collapses afterward. And that's what's crazy to me is like, this sounds wrong, but you guys are tending the house for termites. I know this, you're not poisoning people with termite killer, but it was like, it was in your DNA and how you looked at that issue. And I think that's so critical, is recognizing it's better to spend the money today than save it today for this long-term eruption of an issue.
I think you're absolutely, and the reason why I love health and health insurance, which is weird because it's like a weird dynamic sometimes, but to your point, and I remember us having that conversation, it's having the long-term view is more intuitive because most of us don't have a lot of experience with termites. I mean, I don't, but to your point, like, you have no intuition about whether you should have termites or not. But, we do have intuition as human beings that if somebody comes up, right, like our parents, and they're like, someone says, oh, don't worry, I don't go see the doctor. I never see the doctor. In fact, I don't go to a doctor ever, or I don't go to a dentist ever. Our first reaction is not, that's fantastic, you must be saving so much money. Our first reaction is probably, no, that's not good. You probably, like, a dentist is a great example, right? Like, you probably should go to the dentist every now and then. And I think that's when we tie together that human sort of healthcare level, it does make sense, right? When we're like, yeah, of course you want to get ahead of it. But when you tie to the insurance side and you just look at actuarial tables, to your point, you're like, wow, the MLR looks like this. And the last dimension I remember us discussing is, I think in P&C, if you just have a certain period where you don't have break-ins, you don't necessarily get more break-ins later. It's not like the criminals are like, well, I took a vacation, but I better work extra hard next month, to come back. It just goes back to the mean. Whereas in healthcare, because we're biological entities, it eventually comes back. You can't just, it's not just a lower period.
Yeah. It's it's the oil change in your car. Like at some point, your engine's going to stop working if you never get your oil change, even though you save that $35 or whatever every few months.
That's it. That's exactly right. I think that would be a good example for auto, where we're like, yeah, you probably want to pay for the oil changes.
Yeah.
Like, you know, like how often can you oil change before you're underwater versus the person who never changes the oil,
right?
And you go to total out that car for
right.
a collision. So,
Andrew, one of the other things I want to ask you about before we flip to looking ahead is why an insurer? So this is a thing that boggled my mind, is again, like my PNC lens on is like, oh, this should be an insurtech company that's solving for this, like a data analytics or a solution that carriers are buying. And I know you just tried it originally starting as a healthcare system. Like, why isn't it on the provider side? And why isn't it a solution that all the insurers or hospitals could buy, like electronic medical records?
Yeah. So I think a couple different places. One is that Vivek and I always talk, and I think it's really important that incentives are aligned, right? Mm-hmm. And so when you're the health insurer, that means we are carrying the bag on the total risk of the cost, right? And that means we are incented to find the right ways to pay for the right care over the long term, like you said. Like maybe something that's tempting to look at short term, long term, but either way, we're holding the bag, right? Like we know we are. When you're a provider, you're not often holding the bag on the total cost of care of that particular patient, and which means you can optimize for your own P&L, right? But you're not fixing society's problem. Do you see what I'm saying?
Yeah.
And we're trying to fix society's problem here is every dollar we can be more efficient. Again, pay for every cent of care, pay for the right care, better outcomes. But if we can do that more efficiently, we can allocate those dollars to other people, right? And cover more people, which is really, really important. So I think from an insurance perspective, this is the right place to be, right? You want that feeling of accountability because otherwise you're not going to take the right actions to drive the right behaviors. And so on the provider side, there are providers who take total risk, et cetera, but they're actually relatively few and far between. And we can help bring a lot more providers with Clover Assistant into that mode of care. So you probably saw, like, we doubled our revenues under management almost year over year since last year. That's us helping find doctors who don't know how to move into the insurance type space where they take risk. And as an insurance company, we can ease that passageway, if that makes sense. We're like, you don't understand this very well, nor should you. Like, why would you as a doctor or a health system? We will help you come into this mode, help you move into the future, give you Clover Assistant, and smooth that pathway, which has been very, very effective for us.
The other thing that you said to me is, and I never thought about this, partially because I live in the Boston area, we have a couple of gigantic hospital systems who, touch every, you can be in the Boston area and everything can be Mass General, Brigham, Partners Healthcare. Every now and then you may talk to like Beth Israel Deaconess Leahy, I think is the latest multi-hospital name for that. But they're not everything. And like you said, I go to CVS or go to Walgreens, that's not Mass General. So unless I tell them, they don't know. Or if I'm traveling somewhere, and I go to urgent care or go to a local hospital there, they don't know unless I tell them. And so it was interesting when you're like, as the insurer, we always see all of that. And because ultimately it's all going to get back to your health insurance. So I thought that was interesting, is you are in this unique position. And then you talk about the incentives. And again, you're uniquely positioned from an incentive standpoint to want to do the right thing, except for the long-term view. And I think that has to be like, that to me is where the choice for an insurer comes in, where you guys clearly have chosen that. And I think for a lot of carriers, they get stuck in the immediate term impact financially. And that's where it's, pre-approvals get denied because they don't want to spend on it without recognizing, like, wait, we're going to spend so much more over the next 5 years with all the visits we're going to have and all of the care and all of the expense that's going to come from this morbidity issue we're creating by saying no up front. It does seem like something you have to stay really conscious of.
And I think that taking it to insurance, I completely agree with you. Like, as an insurance company, we're well placed, right, for that longitudinal set of data you mentioned to follow our members, our patients, like as they go down their life's journey. I think that the other angle that we should call out here is that it's very unnatural for a commercial health insurer, right? And so many health insurers are dominated by commercial health insurance and versus we're only in Medicare, right? Yeah. But if you think about that, really, you don't control your own joining and churning necessarily as a commercial health insurer. You'd be like, well, why should I pay for Bryan's care now? For all I know, Bryan's going to change jobs in 6 months. And it's not like, even if you loved United, maybe your new employer's on Aetna, if you see what I'm saying, right? And you don't have any control over that, right? And so you can't say, no, I want to stay on United under that scenario. So they're not super incented to actually try to make those longer term investments, right? Now with Medicare, you can change plans every year, but generally it's more sticky. People can stay with you. People can like their plan and stay with it. And so we are able to have that longer term view than versus say a commercial insurer. A little harder there because it's driven by employer choice.
No, it's an interesting point. I mean, the dynamics are fascinating and infuriating to me. But it's an interesting point. You may be in a unique position or easier position to be able to take that long-term view. But I would challenge those on the commercial side. It still is the right thing to do. It still could lead to better outcomes, as you're showing. But it's a huge shift, a cultural ethos kind of shift. I do shifting. Speaking of shifting. Just before we go, looking forward, where is this all heading? Like, what's the ultimate future state for health insurance that you see or that you're working towards or trying to catalyze? Is it, well, yeah, I'll leave it there. Like, what do you see happening?
Yeah, absolutely. I mean, we talked about, in the book, you talk about it and we've talked about it where ultimately, like we think back to why is healthcare powered by insurance in the first place, right? And it's something I mentioned to you, which I think was another thing that I caught my mind of health insurance is like health insurance is one of the only places where people want to utilize insurance sometimes, right? Like, no one wants to get in a car crash, right? But with health insurance, you want to use your health insurance. Yeah. So if we are able to get past what you've called out several times, which is correct, I would see that we're on like a local maxima, right? Like why the reason it's hard to get off the local maxima is because it's working. It's working for a certain set of folks in the US, not everyone, but a certain set of folks. It's working for certain health systems, certainly for certain health insurers. It's a profitable way to deliver healthcare. And some of us who are very lucky, we get pretty good healthcare at the end of the day, right? Yeah. It's time we need to move to the next global maxima, which is hard, right? Which is why Clover is one of the few folks trying to do this, is because the local maxima is enticing. It's another way to say innovator's dilemma, right? Is to be on there. Where we need to go into the future is pretty obvious, is we need more physicians, providers delivering care. They need to be spending more of their time delivering that care and not doing documentation and trying to do billing and all these kinds of things. At the same time, we need to also figure out how we can allocate capital to provide for these better experiences for our patients, to provide for better experiences for doctors. And I do think that the US, I know we're always sort of like, it's fun in the US to malign the US healthcare system, right? But I do think that we have a proven model of innovation where other countries, it's not perfect in other countries either. Right. And they're sort of bogged down by their socialized systems or entitlement systems. And finding that right hybrid for the future is going to always involve physicians, data-driven physicians who have all the information at their fingertips and who are able to just sort of give better care with sort of less time being dedicated to overhead. Yeah. All of this inefficiency is a place where no matter which model of care you like, whether it be like the European social systems or the US system, private insurance, government funded insurance, single payer, right? Like all of these are means to play with going to the same place. What's missing is just focusing on the care being delivered by the doctor and bringing together that payer-provider relationship even closer. Yeah. It's too often adversarial. By bringing it closer together, using technology to bring it together, we end up in a much, much better place, I think, under all paths in 3, 5, 10 years' time.
Yeah, that's a great picture for the future. And I think the adversarial point hits home. I think that's the norm. And the good thing about that is that continues to be a choice. Like we can actually stop feeling that way and try to work together.
Very well put.
For saving lives, ultimately, and doing it more efficiently, because we are tying up a lot of capital in provision, not necessarily on the innovation side, and we're not getting the outcomes that we're wishing for. So we could change something. Andrew, I'm really glad we got to sit down again. It was power packed. We blew through stuff, but I think it's so important. And it's especially a place, health insurance, where absolutely we need to start to make changes. And I think you're right. That's that sort of apex point where we can change the delivery of care and the receipt of care at the same time. We need to think about the patient. So thank you so much for sitting down with me again today.
Thanks so much for having me. Always a pleasure.
It was great to sit down with Andrew again. I got to spend a bunch of time with him. But yeah, it's been a while now. We spent a couple hours, at least maybe 3 hours together on Zoom, and then back and forth and email and drafts, just working through getting the story right to share with all of you in the Future of Insurance Volume 2, where Clover Health is the lone health insurer in there. There's Beam Dental, it's sort of health. It's dental. It's a little bit different, but I thought they were an important case to bring to you because, yeah, there's some noise around them and the whole meme stock scene, but put that aside, it is a very real and materially different approach to solving not just the health insurance issues that we face in this country, but also the healthcare outcomes and the delivery of healthcare. It is a real problem. We do have amazing healthcare, but it's incredibly expensive. And if we were just spending that money and getting the best outcomes, well, then you could say it's totally worth it. But you know what? We don't have the best outcomes, and that's not subjective. That is a fact. We have, all the spend, and we don't have the longest longevity. We don't have the lowest issue rates for things like diabetes and obesity and all the things that come along with that. We don't have the best health, and that's just a fact. And actually, the US has been slipping further and further back. And that's all before the pandemic. Who knows what things will look like after that, because everyone globally has been getting hit. But the fact still remains. US healthcare, while an amazing thing and highly innovative and driving a lot of the advances in healthcare and healthfulness globally, is still not delivering the results we need to at home. And I love Clover's reason for being is to help move that needle, to help change that paradigm, and to help more people get more care, more coverage for better outcomes, which is the whole purpose. And I think Andrew brought a lot of the key facets of that to this discussion today. So thankful that he took some time. He is incredibly busy, but he took that time to sit down and share that with you. I hope that was interesting. If this is something you want to learn more about, of course, check out Clover. You can read their case study in the book, and I go into their genesis story in more detail, some of the ups and downs, and what they're trying to build and how it's playing out. I think it's a fascinating thing. Yes, I'm biased because I wrote it. I think it's really good, but as a P&C person, it was incredible to dig into this other side of insurance and this other world that we have. I think it's really neat. And it's a side that, from my perspective, as a consumer of it and an observer, I think it has a lot of issues. And unfortunately, in P&C, we're a little bit spoiled. There's so many great solutions coming to bear on the insurance delivery. In health insurance, not so much. And I'm not totally sure why, because dollar for dollar, it's huge. It's a humongous part of the insurance world. The largest insurer in the world is a health insurer, US-based United Healthcare, over $200 billion a year in revenue. That's crazy. I mean, we think, State Farm and Chubb and Allstate, like AIG, huge companies, they are, but they're teeny in comparison to what we have on the health insurance side. And I think that's just wild. We should be digging into this space more and seeing how we can drive it forward. So I commend Clover for doing that. So I want to thank Andrew for taking the time out of that very important mission to sit down with me yet again to share some of that insight. Hopefully it's inspiration for all of you. And I want to thank VPay for standing by the show. They've sponsored a bunch of episodes, yet another one here today. Check them out at vpayusa.com. And thank all of you for listening. It's been almost 50 episodes across the show, across 2 seasons so far. Thank you for sticking with me. I hope this has been interesting. If you've just come in partway through this season, or maybe you started with this season and not last, you can always catch the old episodes at future-of-insurance.com/podcast. Or if you just go to future-of-insurance.com, just click on podcast at the top of the page. Thank you, and I will get back to you all soon. Take care.